Hello everyone, my name is Felipe Teran. I'm the current Academic Chief Resident at Mount Sinai.
And I'm Lara Vanyo, a current PGY3.
This is a module that will teach you to identify regional wall motion abnormalities in echocardiography and how this can help to your patients. This teaching module is brought to you by the Division of Point of Care Ultrasound of the Mount Sinai Emergency Department in New York City. No matter what the level of medical training you have, chances are that you have been taught the use of electrocardiography to identify ischemia when assessing a patient with chest pain in whom an acute myocardial infarction is suspected. Not only emergency physicians, but doctors in general, and even medical students are expected to learn how to recognize ischemic events on EKG. The rationale is to identify which region or wall of the heart is being affected based on the leads that are compromised. But getting a three-dimensional picture is often tough and certainly requires practice with EKG. In addition to that, while EKG changes and the appropriate clinical context are highly specific, they are an indirect manifestation of coronary ischemia reflecting conduction problems in an ischemic myocardium. So what if we could include as part of our assessment an actual functional picture of that ischemic myocardium? Echocardiography allows us to assess myocardial dysfunction in real time. This can be helpful and has been proved to enhance identification of acute ischemic events used as an adjunct to EKG. Previous studies have shown that regional wall motion abnormalities, that is, the dysfunction of one specific region or segment of the ventricle due to an ischemic insult, to be the first sign of acute cardiac ischemia, even before chest pain or electrocardiography changes. The investigation of regional wall motion abnormalities is a Class 1 recommendation by the AHA for patients with suspected acute coronary occlusion, as the presence indicates that a large area of myocardium is an imminent risk of death. Based on the views obtained in both transverse plane and sagittal planes of the heart, the American Society of Echocardiography has divided the left myocardial walls into 17 different segments. While this is shown to have better sensitivity than EKG, allowing a much more accurate assessment, this is complex and not designed for point-of-care sonographic evaluation in the emergency setting.
Fortunately, a simplified approach to assess regional wall motion abnormalities has been described and used in studies in the emergency department setting. This method breaks down the left ventricular anatomy into three main regions: anterior, inferior, and lateral walls. Each of them correlates roughly with the main coronary arteries involved: the LAD, left circumflex, and the right coronary artery. In order to learn how to identify them in cardiac ultrasound, let's first remind ourselves of the normal anatomy seen in the three cardiac windows we use. We like to start with the parasternal long axis view by placing the probe somewhere around the third intercostal space on the left sternal border, with the probe pointing towards the patient's right shoulder. In this view, we are cutting the heart in a long axis, or sagittal plane, and if appropriately centered, we should be able to identify the right ventricle on top, aortic outflow tract and aortic valve, left atrium, mitral valve, and left ventricle. Take a moment to recognize the structures and think, where would you assess each of the left ventricular walls? Got them? No worries, here it is with color. On the top of the screen, we have the septal wall, which shares similar coronary distribution with most of the anterior wall, by the LAD, here in red. On the left side of the image, part of the lateral wall, irrigated mostly by the left circumflex. And finally, in yellow, in the center bottom, the inferior wall, largely fed by the RCA. By staying in the same position and rotating the probe clockwise 90 degrees, we get a transverse or short axis view of the heart. By moving in the direction from the patient's right shoulder to his left hip, that is following the heart's axis, we can see the same view at the level of the mitral valve, as shown in this picture, or further down at the level of the mid-papillary muscles, or apex. Now to the video. Do you recognize each of the walls? Remember, this is a transverse section of the heart, so the right ventricle is on the top left of the image, and the region of the left ventricular wall that is closest to the probe corresponds to the anterior wall, while the inferior wall is seen on the left of the image and the lateral wall on the right of the image. Let's make this even more clear by adding color to the walls and reminding ourselves of the arteries that most likely are compromised when each of these walls or regions are affected. Finally, the apical four-chamber view is obtained by placing the probe in the fifth intercostal space. and the left midclavicular line with the probe's marker directed towards the patient's left side. As the name in this view, we see all 4 chambers, allowing evaluation of the anterior wall and the septum. And here is a clip of a normal apical 4-chamber view. Pay attention to how the septal wall and anterior left ventricular wall are contracting symmetrically, coming together during systole. Here, one more time, the same clip with coloring to help us memorize the anatomy and the regionalization for the assessment of wall motion abnormalities. Now this EKG highlights exactly which leads correspond to which regions of the heart. Thinking back to your board exams, you will remember that the 3 primary arteries of importance feeding the different regions of the heart are the right coronary artery, or RCA, which generally feeds the inferior heart, the left anterior descending artery, or LAD, which generally feeds the anterior heart and the septum, and the left circumflex artery, which generally feeds the lateral heart. We can therefore think of the EKG leads in terms of coronary distribution as well, following this anatomical simplification. Now let's take a look at some pathologic EKGs and see if we can identify which region of the heart and corresponding coronaries are likely to be involved. Do we see signs of infarction here? Certainly. We see ST elevation in leads 2, 3, and AVF. This corresponds to the inferior wall, which is generally supplied by the RCA. Where do we see contiguous ST elevations in this EKG? In the precordial leads, V1, V2, V3, V4, which correspond to the anterior and anteroseptal walls. Here we see this highlighted in red. Where do we see ST elevations on this EKG? In 1, AVL, V5, and V6, which correlate to the lateral wall. Here we see that the lateral wall is likely to be involved, which is generally supplied by the left circumflex artery. Here we see this highlighted in blue.
See how useful this could be for your next patient with chest pain? Remember, those patients who have regional wall motion abnormalities on cardiac ultrasound are at higher risk for myocardial death than those who only have EKG changes. So can we add this interpretation of echocardiography to the emergency evaluation of high-risk patients as an adjunct to the EKG? Sure we can. Let's practice with some examples. Let's go back to this EKG we saw, with ST elevation suggesting acute ischemia in the inferior leads, which we know corresponds to the inferior wall. Think for a moment, where would you look for regional abnormality in the echocardiogram of this patient? Here it is on a parasternal long view. Pay attention to the same clip now by looking carefully to the inferior wall. You can see how the part of the ventricle is not participating as well as the other segments. What about our parasternal short axis? Where do we expect to see a regional wall motion abnormality here? Look to the inferior portion of the heart and slightly to the left, where the right side of the heart falls and where the RCA would feed to. Finally, where do we expect to see an inferior wall MI on the apical 4-chamber? Exactly. The RCA feeds part of the intraventricular septum along with most of the inferior wall, as shown in the clip on the right. Look carefully and see how the image on the left, the inferior septal region is not contracting as well as the rest of the left ventricle. This is consistent with the changes we saw in the EKG.
Now let's look at this one. We have a patient with active chest pain. Where do we see ST elevations in this EKG? It seems to be the anterior leads, mainly correlating with an LAD lesion. In fact, we already saw this EKG, but let's see now where the anterior wall is visualized on echo. This is a slightly rotated parasternal long view. You can see how the anteroseptal region here is contracting abnormally. If you're having trouble identifying this, put your hand and cover the rest of the walls and focus on one segment or region at a time. By doing that, the abnormality becomes much more clear. Just like EKGs, there's a learning curve for this skill. The more you see, the better you will get. Of course, you have to know what you're looking for. Here's a parasternal short view of the same patient. Look at the anterior wall on top of the image. Clear, right? Sometimes the abnormalities will not be completely evident in one view, but integrating the information and looking directly at the same regions in each of the 3 views, parasternal long, short, and apical 4-chamber, will allow you to pick them up. Here it is side to side with our colored image.
And in case you're still not convinced, here it is the same patient, now on the apical four-chamber view. And here next to the normal colored image, look at the region corresponding to the anterior and septal walls irrigated by the LAD. In our clip on the left of the screen, this wall is barely contracting. Finally, where do we see the MI here? It is along the lateral wall, fed by the left circumflex. Ready to see the echo? Pay attention to the lateral left ventricle wall on the left of the image. Remember the colored region that corresponds to the lateral wall? We made it blue for the purposes of this module. Here it is. See how there's no great contraction on this region compared to the rest of the segments? Alright, let's wrap it up. In order to assess regional wall motion abnormalities, you need to remember 3, 3, 3. 3 echographic views, 3 left ventricular regions, and 3 coronaries irrigating most of these regions. The 3 views are the parasternal long axis, the parasternal short axis, and the apical four-chamber view. The 3 regions are the anterior wall corresponding to the left anterior descending artery, the lateral wall corresponding to the left circumflex, and the inferior wall corresponding to the RCA. Here we see all 3 views with all 3 walls highlighted and correlated to an EKG. Hopefully, by the end of this workshop, we will be able to identify regional wall motion abnormalities and relate them back to an EKG.